Hello and welcome, my friends. I'm Dr. Syed Kazmi. You're watching my YouTube channel, which is known as the Medical Channel, which means the world of pediatrics, public health, and epidemiology simplified. Today, I'm going to talk about bronchiolitis. Bronchiolitis is a very common illness of the infants. By definition, it is actually an acute viral infection of the terminal bronchioles in the lungs. It's mostly caused by respiratory syncytial virus, but we have seen that the summer wave of bronchiolitis is nowadays being caused by the human pneumometavirus. But still, as far as the overall global incidence is concerned, respiratory syncytial virus is still the number one viral cause of bronchiolitis. It's a highly contagious illness and is spread by droplets. And that's why they say that hand washing is one of the most effective way to prevent bronchiolitis, but nevertheless it's so common that personally I think that no child in UK can escape bronchiolitis. Probably the incidence is almost 100% when a child reaches 2 years of age. Now mostly it occurs in winters and early spring. But after this COVID wave, we saw, last year because of the COVID global restrictions, the lockdowns, we didn't see much of bronchiolitis even in autumn and winter. But now as the lockdown has eased, we are seeing more of a summer wave of bronchiolitis and the cases are picking up. So the early lockdowns might have contributed to control of this thing, and as now the lockdowns have been lifted, people are more mixing up, so we are seeing more and more of bronchiolitis happening in infants. Now, usually sometimes there is a history of, as far as the risk factor is concerned, history of prematurity is a risk factor. Similarly, a child who was put on a mechanical ventilator for any reason, that is also one of the risk factors. Now, coming down to the clinical picture, how bronchiolitis presents. Now, bronchiolitis can present in many ways. The most common presentation is usually a prodromal period of coryzal symptoms for 1 to 3 days. So a child starts having snuffles, runny nose, sneezing, a bit of cough for 1 to 3 days. It might be associated with mild grade fever. Sometimes a history of fever might not be there. And these 1 to 3 days of coryzal symptoms are followed by difficulty in feeding. It might be followed by persistent cough, but the most common presentation after 1 to 3 days of these prodromal symptoms is usually difficulty in breathing. So the parents would report that the child's chest is moving very fast, or his chest is getting sucked in, which we call as chest recessions. When you examine these charts on auscultation, you might find that there might be an element of bilateral wheeze, or might be element of bilateral crackles, crepitations as we call them. Now, wheeze is not that much common as compared to crepitations. So remember, these are not the essentials of diagnosis. As I said, you might find them on examination, but sometimes you might not find them. It might be just tachypnea with chest recessions and a runny nose and a bit of cough for 2 to 3 days. In small children who are less than 6 weeks of age, especially if there is a history of prematurity, sometimes bronchiolitis might only present with apnea, like there is nothing else, but the child has got occasional cough and then he stops breathing for a couple of seconds, and the lips might turn gray or blue during that particular time. So it can present like what we call as briefly resolved unexplained event, which was formerly known as ALTE, apparent life-threatening events. So they can present like that as well, and we see in our daily practice 1 or 2 cases per day when the season is at the peak. Ambulances bringing in small kids who have got a history of prematurity, and parents suddenly noted a very frightening event that he stopped breathing, and they eventually turn out to be having bronchiolitis. And sometimes these kids, once the bronchiolitis, it's a self-limiting illness. Once the bronchiolitis finishes, they still might have recurrent wheeze after some time. Since the illness is quite common, you should remember that what are the indications for hospital admission. Now, any child who has got a respiratory rate of more than 60 breaths per minute, now that is an indication for hospital admission. Somebody whose feed takes a hit, so if the feeding is less than 75% of their normal oral intake, that's another what you call indication for hospital admission. If there are risk factors like prematurity, history of prematurity, history of congenital heart disease, history of congenital lung problems, obviously that's another indication for admission. Or if a child is clinically hydrated, or if the child oxygen saturations at the time of admission are less than 92% on room air, so they need to be admitted. Similarly, of those who are admitted, some kids might, this is a very small percentage of the kids suffering with bronchiolitis, but some of them they'll usually land up in intensive care units. They have to be retrieved to pediatric intensive care units. And these are the kids who have got like multiple comorbidities like prematurity, congenital heart problems, blah blah, so on and so forth. So if these kids, if they have got an observed or reported apnea, they might land up in intensive care admission. They might have to be kept over there. Or if there is severe respiratory distress, like in the form of central cyanosis, grunting, markedly increased respiratory rate, like greater than 80 breaths per minute, or if the sats are persistently low, less than 92% on room air, definitely then intensive care admission has to be considered for these children. Now the risk factors, though, as I told you earlier, that well, here in UK I've seen like the incidence is almost 100%, but you still must remember what are the risk factors for bronchiolitis. Who are the kids that might be more prone to develop bronchiolitis as compared to their normal counterparts? So if there's a history of maternal smoking, this is one of the biggest risk factors. So if the parents are smoking, these kids are more prone to develop bronchiolitis. If they come from the low socioeconomic status, so obviously if they are poor, they're on benefits, there are more chances of these kids to have bronchiolitis. Obviously prematurity, as I discussed earlier, less than 32 weeks, that is a risk factor. Gender wise, males are for some reason more prone to develop bronchiolitis as compared to females. And another risk factor is not doing breastfeeding. So kids who are not breastfed, again, they have got more chances of having bronchiolitis as compared to those kids who are breastfed. Now as I said, it's a common illness in infants, but there are some of other illnesses which can present with more or less the same picture. So you should know what comes in the differential diagnosis. So the differential diagnosis, number one, is lobar pneumonia. Now obviously lobar pneumonia is a more serious condition. So in that particular case, you would see more high-grade fever. Probably on auscultation, you might find that the breath sounds are absent, or there might be bronchial breathing rarely, sometimes over one of the lobe. And obviously if you do a chest x-ray, you might see that there is some form of consolidation, lobar consolidation on the chest x-ray. The other common differential diagnosis is bronchopneumonia. So bronchopneumonia is another form of viral infection of the lungs, but obviously it's not caused by respiratory syncytial virus. It doesn't present the way that the bronchiolitis present, but nevertheless it's still a viral infection, and it can cause the same type of clinical picture. Then viral wheeze is another differential diagnosis, which is more common as the child grows older. So usually around 18 months to between 5 years of age, kids who have got an upper respiratory tract infection followed by difficulty in breathing, majority of them, they turn out to be having viral induced wheeze, which we call as acute viral wheeze. Aspiration pneumonia, kids who have got underlying neurological problems like cerebral palsy, or who have got pharyngeal muscle incoordination or gastroesophageal reflux, they might aspirate a bit of their gastric contents, and that also presents as recurrent wheeze. So the clinical picture will be similar, but there is usually a chronicity or recurrence of the symptoms. So you should be considering gastroesophageal reflux in that case, especially if the child has got a history of throwing up after the feeds and things. Tracheomalacia is another condition where there is a floppy trachea that can present with a picture which is similar to bronchiolitis. Obviously there will be no fever in that particular case. Interstitial pneumonitis, then as I told you earlier, gastroesophageal reflux disease, which can present per se, or the effects of that in the form of aspiration pneumonia, or aspiration can present as recurrent wheeze. And sometimes non-pulmonary problems like congenital heart disease, especially congestive cardiac failure, which could be because of different types of congenital heart problems, so VSD, ASD, total anomalous pulmonary venous drainage, and sometimes acquired conditions of the heart like myocarditis. They can cause wheeze. So a child might be having tachypnea, but the chest is clear to auscultation, there is no history of fever, and usually if you do a chest x-ray you might find that the heart is enlarged, or if the center has got echo facilities and you do the echo, so you will get a definitive diagnosis in that particular case. Now, as far as investigations for bronchiolitis are concerned, no investigations are routinely required. It's a clinical diagnosis, so you diagnosed on the basis of the clinical presentation, the age and the risk factors. Sometimes if you are not sure, then, or if the child has got high temperature or something, then obviously you can do full blood count, UNEs, LFTs, you can take blood cultures, you can do a chest x-ray, and you can do a workout for sepsis as well, like doing lumbar puncture and doing urine culture and sensitivity. But in most of the cases, routine cases, no investigation is required. It's a clinical diagnosis. Sometimes we do chest x-ray to see if somebody is coming with complaints again and again, or if there is more than one attack of bronchiolitis in a season or something. So we do a chest x-ray to see if there is a component of lobar pneumonia, or if there is any underlying problem in the lungs which might be picked up in a chest x-ray. So that sometimes we do chest x-ray. But other than that, I mean, usually if you do a chest x-ray in an ordinary bronchiolitis, you might see patchy infiltrates, increased bronchovascular markings, and sometimes even patchy consolidations as well. So, but these are quite non-specific findings, and can present in so many other conditions as well. Now, when we do the chest x-ray, when we do the workup, number one, if we are suspecting pneumonia, obviously if the child is too much ill, or if there is a prolonged or protracted illness, obviously it's usually most of the cases of bronchiolitis, they get better within 5 to 7 days. So if it's prolonged, then obviously we do chest x-ray to see if there's any underlying problem. So again, as I said, on chest x-ray you would mostly find hyperinflation or patchy consolidation, or few what you call patchy atelectasis as well, which is usually on the right upper lobe or right lower lobe as well. Routinely, we don't do the nasopharyngeal aspirates for respiratory syncytial viruses. Some centers they do it, but routinely there's no need of that, because that doesn't change the management. So there's no point in running whether it's caused by RSV or whether it's caused by human pneumometavirus. The management does not change. Now coming down to the complications. Most of the cases of bronchiolitis, they don't have any complications. I mean, it's just a mild illness, mild to moderate illness, goes away within 5 to 7 days. Usually the peak is that in the first 3 to 5 days the graph goes up no matter whatever you do, and after that there is a plateau, and then it gradually resolves. Sometimes it can lead to a serious complication which is known as bronchiolitis obliterans. Now, what is bronchiolitis obliterans? This usually occurs in older children, not in the very young one. Older children, like above 1 year of age. So mean age is around 16 to 20 months. Sometimes it can happen as a late complication of bronchiolitis as well. Child had bronchiolitis early, but later on then it leads to chronic changes in the terminal bronchioles. We have seen that mostly those kids who have bronchiolitis and have super added infection by adenovirus, somehow they are more prone to develop bronchiolitis obliterans. And some kids who have got transplants, different types of transplant, they are also prone to develop bronchiolitis obliterans. What happens in this particular illness is that there is formation of granulation tissue. So once the terminal bronchioles are damaged by infection and inflammation, later on there is formation of granulation tissue, and granulation tissue leads to fibrosis, and fibrosis leads to obviously the terminal alveolar sacs, and they are destroyed, so there is no more surface for exchange of gases. And sometimes if it is severe, can lead to just deformity as well, because fibrosis, fibrous tissue contracts, so there's scarring on the lungs, it contracts, and obviously because the chest wall is quite compliant, it's very soft in infants, so well, there are more chances of chest deformities in these children. So usually how bronchiolitis obliterans, which is a complication of bronchial, how it presents, there are no signs of infection. Basically, there is usually a weight loss or fatigue. Fatigue is there in the children because the alveoli have been destroyed, and obviously there's not enough surface area for gases exchange, so the child is not getting enough oxygen, so they get out of breath. They are very much like fatigue. There's also a triad of chronic dry cough, chronic or persistent respiratory distress, which is more prominent on exertion, and there is an element of chronic wheeze as well, which does not respond to bronchodilator therapy, or even kids have been put on inhaled steroids and they do not respond to that. So somebody who had a history of bronchiolitis and they've got a chronic wheeze, they've got a chronic or persistent respiratory distress, which is more prominent on exertion, they've got a chronic dry cough, and especially if they've got the risk factors, then you should be thinking of bronchiolitis obliterans as well. You might also find, as far as the examination findings are concerned, you might find on your chest examination that there are craps, there are wheezing, the child might develop clubbing as well. And if you do a chest x-ray, you might see that there is a unilateral hemi-translucent chest. You can do a CT of the chest as well, which can give you a more clear picture, and you can diagnose it on the CT. Obviously, the most appropriate confirmatory test is biopsy, but obviously biopsy is not done these days. It's mostly a CT, which can pick up the diagnosis of bronchiolitis obliterans, and then it can be treated. As far as the treatment of bronchiolitis obliterans is concerned, there is remember, the antibiotics are of no use. Antibiotics, even if you give them, the child would not have any improvement. Some people, they do give a trial of inhaled steroids and bronchodilators to rule out asthma, because you know that asthma is a condition in which the bronchospasm actually responds to bronchodilators and there is an improvement. But usually in case of bronchiolitis obliterans, there will be no improvement to bronchodilators or steroids. Now, as far as the treatment, now coming back to the bronchiolitis, now as far as the treatment is concerned, National Institute of Clinical Excellence here in UK, which is known as NICE, it advises us that we should not be routinely using the following drugs. So it strictly advises against, remember the word is against, the use of, number one, antibiotics, because antibiotics have got no role in bronchiolitis. It's a viral illness. Some people, they use hypertonic saline. Now research has shown that hypertonic saline might decrease the mean hospital stay by 1 day in kids who are hospitalized, but that doesn't mean that it should be routinely used in cases of bronchiolitis. So it advises against use of hypertonic saline, which is 3% sodium chloride, and is given as a NEP. There is no role of nebulized adrenaline, which is used for croup. We do not use it in bronchiolitis. There is no role of salbutamol nebulization, again because this is not asthma. There's got no role. There's no role of giving them montelukast. There's no role of giving them Atrovent or ipratropium, and there is no role of systemic or inhaled steroids. So all these drugs should not be routinely given to a case of bronchiolitis. So in other words, there is no treatment for bronchiolitis. Just wait and see. Yes, the only treatment that we give is supportive treatment to those kids who need it. So if the child has got room sats, oxygen sats less than 92%, then we admit them. We just give them oxygen, and we give them oxygen for the time till the recovery process is there and the sats, they return back to normal. If they're too much bunked up at the back of the nose and they've got issues with feeding as well, so we can do a bit of suctioning to clear up the mucus. The other thing is to keep the child well hydrated because of the respiratory distress. There are insensible water losses, so it's very important to keep the child well hydrated. So breastfeeding or bottle feeding, whatever, has to be encouraged. If not, you can pass an NG tube and you can give the feeds through that. And obviously for kids who have been admitted, regular cardiopulmonary monitoring is important to detect for any apneas. Children who have got severe form of bronchiolitis sometimes might not respond to routine oxygen, so they have to be given high flow humidified oxygen. We call it as vapotherm. So that vapotherm can be given to those kids who are have got severe respiratory distress. And what happens in vapotherms, that you are giving high flow oxygen, so the oral cavity, nasopharyngeal cavity itself becomes a reservoir of 100% oxygen, from which it's easy for the child to breathe in from his own reservoir of oxygen. So it just helps in increased work of breathing. This is how we treat bronchiolitis in hospital. And for those kids who have got mild form of bronchiolitis, we just tell the parents that they should keep an eye on the child. They should put saline nasal drops just to clear the nasal secretions. They should encourage the feeding, and if the respiratory distress increases or if there is severe indrawing of the chest, then we give them safety netting so that at least they are reviewed by a health visitor or by their healthcare provider. So in case if there are any complications, that can be picked up earlier and they are sent to the hospital. But as I said, even if they are admitted, usually it's all supportive therapy, giving them oxygen either through face mask, or if it is severe respiratory distress, then obviously we go with vapotherm, which is highly which is humidified high flow nasal oxygen. Some kids who have got a history of prematurity, they might be given a monoclonal antibody as a vaccine, and that monoclonal antibody that is used to prevent RSV bronchiolitis is palivizumab. So 5 doses are given. These are usually given to kids who are extremely premature, born less than 32 weeks gestation, or who have got underlying congenital heart problems or congenital lung problems, or have been severely very low birth weight. So it's a very expensive thing, so it's only given to those kids who have got these indications. It's not routinely given to term babies to prevent bronchiolitis. So these are some of the issues surrounding bronchiolitis. So we have discussed the etiology, we have discussed the clinical presentation, we have discussed the investigation, and we have discussed the treatment as well. Quickly to go through some of the now quickly going through some of the questions or some of the scenarios and how to formulate a diagnosis. Like for example, let's say there is a 5-month-old baby who has got a widespread wheeze on his chest and crepitations, and the O2 sats at room air are 89%. So what would you do? So this is a classical case of bronchiolitis, and if the sats are low, these kids, they need to be admitted and they need to be given oxygen therapy. There is no role for salbutamol or atrovent or any other NAB in this particular case. Similarly, let's say there is a 6-month-old child and he's got a widespread wheeze and crepitations bilaterally on his chest. There is no history of fever, there is no history of coryzal symptoms. It's just that he has got tachypnea, he's got chest recessions, but his O2 sats at room air are, let's say, 88%. And you also find that he has got a gallop rhythm in his heart, and he's got hepatomegaly as well. So what do you think, what would be the underlying condition? Now this is not bronchiolitis because there is no history of cough or coryzal symptoms, there is no history of fever. The other thing is he's got hepatomegaly, he has got gallop rhythm, so it means there's something wrong with the heart. So this child is in heart failure. The heart failure could be because of any congenital heart problem, so this child needs to be admitted, and obviously an echo needs to be done to see which is the underlying cause, and we might land up in intensive care and might need an early pediatric cardiology consult. Similarly, let's say a 6-week-old baby who has got tachypnea, he has got difficulty in breathing, and you find that the baby has got wheeze bilaterally, a few creps as well, and he has also got a little bit of sticky eyes, yellow sticky eyes. So what do you think would be the diagnosis in this particular case? Now could be bronchiolitis and conjunctivitis separately, but usually you have to connect the dots when you are trying to solve clinical puzzles. And in this case, a child who's got a yellow sticky eyes with features like bronchiolitis, this is probably chlamydia pneumonia. So because it's the same organism which is causing conjunctivitis and it's causing pneumonia as well. So they have to be treated with erythromycin or clarithromycin, macrolide groups of drugs. So that is not bronchiolitis, this is most probably chlamydia pneumonia. So you always have to connect the dots. You have to look at the clinical picture, how it presented. So typically, as I told you, most of the kids up to 18 months of age, they would present with cough and coryzal symptom plus minus fever, and obviously they would be, when they come to the hospital, the usual reason is either persistent cough or usually is difficulty in breathing. So you might find bilateral wheeze, you might find bilateral creps. Yes, if you find signs of heart failure with fever and things, then you should think of myocarditis. If there is no history of fever and things, and the child is just wheezing, is just having fast breathing, then obviously you need to look for cardiac reasons as well. So this was my talk on bronchiolitis. I hope you have gained something from this. You now understand about the etiology, the clinical features, the investigations and the management of this common condition in children. If you still have got any questions, you can put your questions down in the comment section below. I will try my level best to get back to you as soon as possible. And now, for those of you who are watching my video for the first time and you haven't subscribed to my channel, please do subscribe. And if you have liked this video, just then press the like button and share my videos with your friends so that the knowledge is spread to other people as well. And have a very good day. Bye bye.